Hello everyone, Dr. Matt Ed. Welcome back to the channel. Today we're diving into a detailed and guide to understand diastology and transthoracic echocardiogram. Let's start with the basics. Diastology has four phases: isovolumic relaxation, early rapid filling, diastasis, atrial contraction. It is important to understand that ventricular relaxation is not passive. It's actually an active, energy-dependent process. If the left ventricle becomes stiff, it impairs passive filling, leading to diastolic dysfunction. Now remember, diastolic dysfunction often occurs before systolic dysfunction, making early detection vital. Why does diastolic dysfunction happen? Aging, ischemia, or left ventricular hypertrophy can impair relaxation and delay early filling. Increased myocardial stiffness raises left ventricular filling pressures, even when systolic function looks preserved. Elevated left atrial pressure doesn't just stay local. It can transmit backwards, affecting the pulmonary circulation. Common culprits include hypertension, diabetes, hypertrophic cardiomyopathy, coronary artery disease, and infiltrative diseases like amyloidosis. When it comes to echo, we use a multi-modality approach. 2D echo helps to estimate the left atrial ventricular index, also known as LAVI, wall thickness, and systolic function. Pulse wave Doppler captures mitral inflow patterns, including the E/A ratio and deceleration time. Tissue Doppler imaging measures E' velocities at the mitral annulus. And other helpful tools include cutter end mode, strain imaging, tricuspid regurgitation velocity, and LA volume. These support estimation of left ventricular filling pressures. The mitral inflow pattern is your bread and butter. E wave, early diastolic filling. The normal peak velocity is 0.6 to 1.3 meters per second. And the A wave is atrial contraction. Now, the E/A ratio gives us insights into whether it's impaired relaxation, pseudonormal, or restrictive filling pattern. So, E/A ratio less than 0.8 indicates impaired relaxation. E/A ratio 0.8 to 1.5 indicates pseudonormal. And E/A ratio greater than or equal to 2 indicates restrictive filling pattern. Each of these patterns correlates with a specific grade of diastolic dysfunction. Tissue Doppler imaging lets us look under the hood at myocardial motion. We're looking at E' velocities. Septal E', the normal is greater than 7 centimeters per second, and lateral E' normal is greater than 10 centimeters per second. The way I remember this is 7:11. Then we calculate the E/E' ratio. If it comes out to be less than 8, there's normal filling pressures, and if it comes out to be greater than 14, then there's elevated filling pressures. This is crucial in patients with preserved EF but suspected diastolic dysfunction. Left atrial volume index is the marker of chronic diastolic pressure overload. Normal value is less than 34 millimeters per meter squared. It's measured in the apical 4 and 2 chamber views, and chronic elevation suggests long-standing diastolic dysfunction. The TR velocity and pulmonary pressures. If the TR velocity is greater than 2.8 meters per second, it suggests elevated left atrial pressure. Always interpret this with other diastolic parameters. It adds another layer of confidence to your diagnosis. Now looking at the diastology algorithm. When the EF is equal to or greater than 50%, we use 4 key parameters to help us. 1. The E/E' ratio greater than 14. 2. Low E' velocity. Remember the mnemonic 7:11. So if the septal E' velocity is less than 7, that's abnormal, or if the lateral E prime velocity is less than 10, then that's abnormal. And LAVI greater than 34 ml per meter squared, and TR velocity greater than 2.8 meter per second. Each of these 4 parameters are abnormal here, and interpretation is simple. If there is greater than or equal to 3 of these are abnormal, then there is diastolic dysfunction. If 2 are abnormal, it's indeterminate. Less than or equal to 1 abnormal, then it's normal. Furthermore, to grade diastolic dysfunction when the patient has myocardial disease, such as reduced EF, or if there's like LVH or infiltrate disease, we grade them based on a certain algorithm. So if the patient has grade 1 diastolic dysfunction with impaired relaxation and has normal left atrial pressure, we look at the E to A ratio. If it's less than or equal to 0.8 and their E velocity is less than or equal to 50 centimeters per second, that fits the criteria for grade 1. The patient has grade 2 pseudonormal with increased left atrial pressure. If their E to A ratio is less than 0.8 and the E velocity is greater than 50 centimeters per second, or E to A ratio is 0.9 to 1.9, and if two of the below parameters should be positive, and these include E to E prime ratio greater than 14, LAVI greater than 34, or TR velocity greater than 2.8 centimeters per second. And grade 3 diastolic dysfunction with restrictive and with increased left atrial pressure is simple. You just look at the E to A ratio. If it's greater than or equal to 2, then it's grade 3. Some special scenarios. In AFib, you can't rely on A waves, so how to focus on E to E prime ratio and LAVI and TR velocity. Mitral valve disease alters flows, so use with caution, such as those patients with MAC, a lot of calcium. Diseases like HCM and amyloidosis often show restrictive patterns, and the diagnosis requires clinical correlation and sometimes even biopsy or MRI. So why does this all matter? Understanding diastology is essential for diagnosing HFpEF, risk stratifying cardiovascular disease, and to help guide therapy. Let's wrap up. Diastolic dysfunction is common and carries prognostic value. Always use a systemic, multi-parameter approach, and above all, interpret in the context of the patient. If you found this video helpful, please like, subscribe, and look out for my next video. Thank you for watching.